This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2015, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director of Education at the AARC. I welcome you to today's presentation, Ethical Dilemmas in Respiratory Therapy. Upon completion of today's webcast, participants will be able to discuss ethical principles as they apply to patient care, apply ethical principles to patient care dilemmas, and describe the role of a hospital ethics committee. I am pleased to welcome Dr. Linda Van Scoder. Dr. Van Scoder is a registered respiratory therapist and fellow of the AARC. She is the program director for the Indiana Respiratory Therapy Education Consortium in Indianapolis. Dr. Van Scoder is actively involved with the Indiana Society for Respiratory Care and the American Association for Respiratory Care, including serving on the AARC board and serving as chair of the AARC Leadership Institute Education Track. I disclose that I am a paid employee of the American Association for Respiratory Care. Dr. Van Scoder has no conflicts of interest to disclose. Linda, welcome to the program.
Thank you so much, Shauna, and hello, everyone. It is so gratifying to see we have several hundred people who are interested in a webcast on ethics. I appreciate that. Thank you for joining us today. I'm going to start this webcast with a short discussion of ethical principles. I promise it won't last too long. You could spend your whole life studying ethical principles and still have more to learn, so we'll just spend a brief amount of time on that. Most of our time today will be spent discussing cases that present ethical dilemmas for respiratory therapists. Now, you may be thinking, why do we even need to discuss ethics? Don't most people know the difference between right and wrong? Well, apparently not. I now present you with a case I'm calling Dr. Strickland's Dilemma. And Shauna Strickland gave me this information. By the way, names have been changed to protect the guilty in this particular case. So what we're looking for here is, this is a true story, John, name in quotes there, he called the AARC Executive Office for help with one of the continuing respiratory care education credit courses. This one, I'm just going to say COPD education. I don't know if that was right. And this is an online course. It's with the AARC University. And he needed help figuring out if he'd actually finished the course. For some reason, he couldn't tell. So the very courteous staff talked to John, and they asked, which course he was taking so they could walk him through the process of seeing if he'd finished or not. It was at that point John said that the course wasn't even under his name because he was taking it for a friend. His friend, needed the CRCE, but wasn't really interested in the topic, whereas John was interested in the material but didn't really want to pay for it. So he's admitting this over the phone. And here's the capper. John then asked if he couldn't get credit for the course without charge, since his friend was already paying for it, since he was the one actually doing the work and not his friend. John was actually completely clueless that what he was doing is wrong. So this is our first cue that people do have ethical issues. So let's take a look at our next slide here. We're going to go into, just as I said, a brief overview of ethical principles, and there's more to this, obviously, than what we're going to cover today. I've just picked out the ones that I think have the most application to healthcare. So here we have the first concept, and that's beneficence or non-maleficence. And that's mostly just hard to pronounce, but it's fairly simple principles. Some ethicists handle these two concepts separately. To me, they're kind of two sides to the same coin. Beneficence means to provide benefit or to do good. That one's fairly easy to make out. In other words, you have to do what's best for the patient. So you're not doing what's best for you. It is what is best for the patient. That is your primary client here. Non-maleficence means not harming. I think most of us are familiar with the phrase, above all, do no harm. That comes from Hippocrates' writings. And this basically says, You're not supposed to damage the patient. You're not supposed to injure your patient. And in medicine, though, it's not always quite clear. Sometimes we have to balance out these two concepts, balance benefits with harm. For instance, something like chemotherapy or surgery, that's going to harm the patient. I mean, you're cutting them or giving them toxic chemicals, but we do them anyway because the benefits outweigh the harm. And that's what we have to assess in medicine, and that can be difficult to determine sometimes. Not everybody has the same concept of what is benefit, what is harm. So you have to keep that in mind. The concept that we'll look at next is respect for human dignity. And this has a couple of parts. The first one is autonomy. We're going to be talking about autonomy a lot today. The other part of it is, and they're kind of tied together, informed consent. So autonomy, that's the right to self-determination. And it used to be medicine was very paternalistic. The doctor made all the decisions for the patient. That's not the case anymore. Patients have the right to make choices based on their own beliefs and their own values and their own needs. And you have to be careful as a respiratory therapist. You should not try to substitute your religious or cultural beliefs for those of the patient. You have to remember the patient is in control here. An example here, for instance, do not resuscitate orders. I always tell my students, if I have anything worse than a hangnail, give me morphine and let me die, which is only semi a joke. But in some cultures, a do not resuscitate order would be considered unacceptable. You're to do everything to prevent death. The other side of this coin is informed consent. And I think most of you know what this involves. You have to sign an informed consent form if you're going to have any procedure. But the thing is, in order to properly exercise autonomy, patients need to understand the issues. They need to understand what's going on. And this can be difficult. You need to explain things in a manner that they can comprehend. Very difficult. And you may need to explain it to them more than once. I think a lot of us have experienced a situation where, a crisis is going on, a medical crisis. The doctor starts to tell us something, and really our brain doesn't pick up anything past the first sentence. So you need to be willing to explain things over and over and change the wording and explain in a different way if necessary. The last principle we'll talk about today, and then we'll get to some cases, is justice. Justice states that patients must receive fair treatment. That's the main concept of justice. Where we run into trouble is, what is fair? Fair means different things to different people. There are various systems of justice. I picked out 3 here. There are actually a few more than this, but these are the big ones. The first one is distributive justice. And that says basically poor patients should get the same medical care as wealthy patients. So if you're poor or have no insurance or very bad insurance, as a lot of people do, if you're looking at distributive justice, that person should get the same kind of care as the wealthy person who has the so-called Cadillac insurance benefits. That means they should have the same access to expensive medications, sophisticated tests, specialists, whatever. That's distributive justice. Now, a utilitarian system says you should provide the greatest benefit to the most people. For example, if we have limited resources, and we certainly do, we don't have unlimited amounts of money or resources in medicine, this says we should spend money, say, on prenatal care instead of end-of-life care for the elderly. We all know end-of-life care for the elderly is extremely expensive. Prenatal care in the U.S., we don't rank #1 in the world. So if you're using a utilitarian system, you would get more advantage if you would spend on prenatal care than end-of-life care. Now, other people say that healthcare is a business, and you are responsible for paying your own care, paying for your own care. Healthcare pricing should be subject to free market forces as well. This would also say, and this relies on personal responsibility, where the other two are more societal types of things. Under personal responsibility, we would say that people with bad habits, such as smoking or overeating or speeding or riding their motorcycle without a helmet, they should be charged more for health care because we suspect that they're going to cost more in the long run. Now, in addition to these ethical principles, the AARC has a statement on ethics and professional conduct. And there's actually 16 bullet points in this statement. I've just picked out about half a dozen that I think are the most applicable. You can find the full list of the ethical statements on the AARC website if you look under position statements. The whole thing will be there. But the one I want to talk about today, the first one, demonstrate behavior that reflects integrity, supports objectivity, and fosters trust in the profession and its professionals. We want you to clearly understand, and I think pretty much all of us do, when you're out there working with patients, you're not just representing yourself, you're representing your employer, and you're representing us as a profession. People judge respiratory therapy based on their interactions with respiratory therapists. The next point, respect and protect the legal and personal rights of patients, including the right to privacy, that's certainly HIPAA, informed consent, we just talked about that, and refusal of treatment. And that's a hard one if you're a respiratory therapist. You know what you're going to be doing for this patient will help them. They still have the right to refuse that treatment. The next point, provide care without discrimination on any basis with respect for the rights and dignity of all individuals. You treat a lot of people who are very different from you. Maybe you don't approve of the way they live or their religious background or whatever. Too bad. You still have to provide care without discrimination on any basis. First one here. Refuse to participate in illegal or unethical acts, and we'd all say, sure, I have no intention of doing that. I'm a good person. That one's easy. The more difficult one is the next bullet point. Refuse to conceal and will report the illegal, unethical, fraudulent, or incompetent acts of others. This one's hard. You were probably raised not to be a tattletale. But here you have to think, who is your primary duty to? Your primary duty is to the patient, not to your friends, not to your coworkers. Your primary duty is to the patient. And the last point we'll talk about today. Avoid any form of conduct that is fraudulent or creates a conflict of interest, and I would add even the appearance of a conflict of interest is bad here, and shall follow the principles of ethical behavior. This can be a little tricky. The conflict of interest a lot of times comes into play if you have some sort of side business or if you have a relative maybe who has a business interest that the patient might use. You have to be a little careful with that. So, just to recap here, we have your instructions that Shauna already went over with you, so make sure you're finding your little check marks and X's here because we're going to start talking about a series of cases. Now, where did these come from? I didn't just make these up. Some of these were supplied by respiratory therapists who encountered them. I sent out an email on the AARC Connect and asked for people to send me some cases. I asked them to omit any identifying information. We have to be very mindful of HIPAA. And then in addition to that, on the cases they sent me, I may have changed some information or added information for teaching purposes. So what actually ended up on this webcast is actually somewhat different from what they may have sent me. A couple of the cases you're going to see here today, though, those were taken from news reports. Could have been newspapers, CNN, Time Magazine, whatever. And since this information was publicly available and I had no extra information on any of them, I didn't really make any changes in those. So those will be the actual what you see is what you get sort of thing. So you see the directions above. Now, we think we have set this up so that when you vote, the other attendees will not see if you did a check mark or an X. They might see that you did in fact vote, but it won't be which way you voted. So we're hoping to give you a little bit of privacy here if at all possible. So do be honest with us. And we have our first case ripped from the headlines. So this is an actual case, and this happened actually in November of 2013. So it's relatively recent. And in this case, there was a 32-year-old hunter who fell 16 feet to the ground from a tree stand. Now, for the benefit of you city folk who are on this broadcast here, the webcast, I need to explain what a tree stand is. You have to be from the country to know this, or at least be a hunter. This is a platform that hunters build up in a tree, usually fairly high up. You see this one's 16 feet up. And hunters sit up there, sometimes for hours. They got their camouflage on and usually something to mask their scent and whatever. They sit up there for a lot of hours waiting for a deer to wander by or some other animal that they might be hunting that day. And what they do is they sit up there, wait for it to wander by, and then they shoot it. So they need to shoot this deer. And they are supposed to wear a harness to keep them from falling out of this tree stand, off this platform down to the ground. I say they're supposed to wear a harness. Lots of them don't. Falls are not uncommon. My brother fell out of one of these once. He fell asleep and just rolled out of the darn thing. So that does happen. What is uncommon is what happened to this young man. And what happened to this gentleman is he suffered spinal trauma in the fall. He fell kind of funny. And that resulted in paralysis. And the paralysis was that he would be a quadriplegic. He had severe spinal cord trauma. Ventilator dependency, at least initially, there was some feeling that he may not always need a ventilator, but they weren't really sure. So the assessment here was that he would spend, and I'm quoting here, the rest of his life in a wheelchair, and he could be ventilator dependent for that. Now, at the family's request, he was brought out of sedation to decide on his treatment, and I need to tell you the timeline here. He was injured on a Saturday, taken to the hospital. He's on a ventilator, and they brought him out of sedation the following day. So they did this the day after the fall. And when they brought him out of sedation, they assessed his cognitive level. That was fine. And he decided that he wanted life support to be removed, take the ventilator off. I should add to this, he was recently married, his wife was there, and his wife was expecting their first child, just to kind of add to how sad this was. So, what we have here, one day after the injury, just to remind you, he was brought out of sedation and asked, what do you want us to do? He said he wanted to be taken off of life support, so the physician writes an order for the respiratory therapist to turn off the ventilator and extubate the patient. One day after the injury. Should you carry out the physician's order? Go ahead and vote. We need a check mark, green check mark. If yes, you will carry out the order, and a red X. If no, you will refuse. I'm going to give you a few seconds here to vote. And when it looks like a lot of you voted, and be sure you find the green check mark and the red X. I see a lot of votes coming up here. I'll give you a couple more seconds to do this. And we are timing. You got to make the decision quickly, so we're going to close voting now. And Shauna, can you show us the results of that voting? How did our attendees vote here? We'll see if we can get that up. And we have, it looks like 16% say no, 34% say they would extubate and take him off the ventilator, and 50% of you either couldn't decide or couldn't figure out how to work the buttons. So you have a little bit of time to figure that out here too. So, you know, predominance of people would go ahead and do it. A fair chunk of you would not, though. And I can sort of understand why. So what is going on here? What's the ethical dilemma in this case? Why did you have trouble deciding? Well, first of all, autonomy is the case here. Remember we talked about autonomy. Patients have the right to make their own decisions. And remember, I told you there was no evidence of cognitive impairment. He was awake, alert, whatever, when they took him out of the sedation. You also need to know, and I didn't tell you this, so it's kind of cheating, sorry about that. In discussions with his family and friends before the incident, he talked about this similar situation and said that he would not want to live in a wheelchair. So his current decision is consistent with the prior discussions he'd had with family and friends. That's important. Now, for those of you who didn't want to do this, non-maleficence, I'm assuming was your problem with this situation. and that is do no harm. Would he change his mind if he took time to come to terms with the situation? Very often people initially in this situation are, obviously psychologically traumatized, and given time to find out that they can have a meaningful life, they might change their mind, and maybe he would decide he wanted to see his first child. Who knows? So the time element here might argue against it. But what really happened in this situation? Well, what really happened was he was removed from the ventilator and extubated, and he died a few hours later. The reasoning being here, and the reason they didn't wait for more time, was because this decision was consistent with his previous statements, and there was no real reason to believe that he might change his mind. Very sad case actually happened. And I feel bad for the respiratory therapist who had to do that extubation and turn off the ventilator, but it's a decision that had to be made. Okay, the next case we have here. You're the respiratory therapist. You're covering the emergency room in a community hospital, and you're asked to care for a pediatric patient whose mother has just brought him in. And this is the case of the smoking mom. And the child she brought in, it's a 5-year-old boy, and he's been brought to the ER twice in, let's say, the last 6 months, due to asthma. The mother does admit that she smokes in the house. She says she smokes 1 pack a day, but her clothes, and I think we've all been in this situation, her clothes absolutely reek of cigarettes, and you suspect that she smokes a whole lot more than that. The mother refuses to stop smoking around the child. You're trying to talk to her. She's not receptive. She tells you that she doesn't think smoking really has anything to do with her son's asthma. And I think we've all seen this disconnect with smoking and the results in COPD patients or family members like you see here. And she thinks she's a scientist, so she's got a reason for this. She states that her sister smokes a lot more than she does. And none of her kids have asthma. Sister has 5 kids. She smokes a lot. None of them have asthma. You do, as you're looking through the child's chart, you notice that on the boy's record, that the last time they were in the ER, she was advised not to smoke around her son. So she's been advised before. She hasn't stopped. She doesn't believe it's a problem. What to do here? So we're going to vote again in this situation. You need to decide, would you file a report with child welfare, it's called Child Protective Services in some places, that the boy is being neglected? Is this a situation of neglect that you should report the mother for? So you're going to click on the green check mark if you would notify child welfare, the red X if you would not notify child welfare. We'll give you a few seconds. Remember, you got to be kind of quick here on what you're doing, and pick either a check mark or an X. And let me see, we've got a lot of people not voting. Come on, guys, you got to participate here so that we get good results. And we'll give you just a couple more seconds here to vote. And we've got, we're over 200 people who have voted now, so why don't we go ahead and take a look at the results. And we have got, again, about, let's say 20% of those voting, or of the total number, who are going to not report her. A larger number of you will report her to child welfare. It's about roughly a 2-to-1 margin that you would report her to child welfare. So let's see what's going on here. Let's discuss it. So what's the ethical dilemma here? You've got a few of them here. First one we have is autonomy. The mother has a right to smoke. She's an adult. The problem that you have here is it's not an unlimited right. For instance, you can't smoke at work, or in most states you can't smoke in restaurants or any public places. However, on the other side, when we get to autonomy, the society and the law give parents a lot of latitude in how they raise their children. The state isn't allowed to come into the home and tell a parent how to raise their child unless there's a serious problem. Non-maleficence. The child is being harmed. We all know there's good scientific evidence that secondhand smoke can exacerbate asthma. we think that's what's going on here. Third thing that we have to look at here is legal requirements. Now I should tell you this varies from one state to the next. You need to know what the legal requirements are in your state, but you may have a legal requirement to report this as neglect. Does this result in sufficient harm to meet the legal definition of neglect? Probably somebody in the legal department in your hospital would need to decide that. A lot of us, we're respiratory therapists, we tend to see this as neglect. There are others who might disagree with you. So you have, some good ethical reasons to go either way on this. However, you usually don't have to jump straight to the nuclear option. That's what I think, reporting to child welfare would be. There are other things that you can try first. You might try re-educating the mother. Remember I said before, you have to repeat things over and over and over to people. She clearly doesn't understand that she's harming her child. What we hope is she understands and just doesn't care, but that's kind of the rare case. So in order for her to make an informed decision, you have to explain it to her in a way that she can comprehend and really buy into. The other thing you could do is help the mother stop smoking. Remember, nicotine is addictive. It's very difficult to stop. Could you provide her with nicotine patches or gum or anything along those lines that might help? And you can also try to modify where she smokes or how she smokes. Can you get her to go outside to smoke? If you live in Florida, you might be able to convince her to do that. If you live in Minnesota and it's January, probably not. But it's worth a try. And you should, of course, follow any legal requirements, but reporting her for neglect should not be your first option. It probably ought to be your last after you try a few things, because you don't really want to destroy that relationship you have with this child's family, and reporting them to child welfare would certainly do that. Got another smoking case. I'm on a smoking binge today. I guess I shouldn't say that. Our patient we have now is Bob. Bob is 62 years old. He is a COPD patient, and he's been hospitalized for an upper respiratory infection, but he's being discharged in the morning. He has been qualified for home oxygen therapy, and you're the person in the respiratory department who's in charge of making those arrangements. Okay, so he qualifies for the home oxygen therapy. It's your job to sort of make those arrangements. He currently smokes a pack per day of cigarettes, and he says he has really no plans to stop. He says he used to smoke 2 packs a day, so, doing pretty good here. But he just doesn't want to quit altogether, and really, it's just too hard. He's just not into quitting. So what happens here is Bob's physician asks you whether she should write an order for home oxygen, given all the information we have here. Remember, he qualifies for oxygen, but he does still smoke. Should you recommend home oxygen? Click on the green check mark. If yes, Bob should receive home oxygen. That's what you're going to recommend. Click on the X. No, she should not write the order. And let's give you a few seconds to vote here, making up your minds quickly. Yes, some of you are voting quicker this time. I caught you before. So we'll give it a little bit more for folks to vote. Keeping in mind we saw some votes coming in. Okay. And we do have, most of you have voted by now, the majority. So, Shauna, can we go ahead and see what those results are? Okay, so we have some of you who say no, but a lot more of you say yes. And again, we've got about half of you who aren't voting. Got to jump in there, guys. So let's talk about this case. What is our ethical dilemma? Well, one is it safe for a smoker to have home oxygen? I think we all learned this in school. You can't have fire next to oxygen sources. Is he going to set his face on fire? His head would go up like a Roman candle. Who knows? The other dilemma we have is, would you be enabling his nicotine addiction? Well, smoking is legal, and he is an adult, and he has a right to make his own decision. That's the autonomy thing that we have going there. Even if you think it's a stupid decision to smoke when you need oxygen, he has that right. That's how autonomy works. And I will say, unlike the smoking mother in the previous case, he's not harming a dependent child. So this is a different situation from that one. What are your options here? Well, one thing you really have to do is educate Bob on oxygen safety if you're going to give him the oxygen and you know that he smokes. So you can at least make sure he doesn't set his head on fire. I don't think I need to tell you you need to document that education very carefully in case there is a mishap later down the road. You have documented that. That's not the ethical part, that's the legal part. So we're going to educate him, make sure he really understands that. I will tell you, depending on the studies that you read, anywhere from a fourth to a half of the patients on home oxygen do continue to smoke, whether they admit it to you or not. Now, a small number of those do have some sort of thermal injury each year due to smoking while they have their oxygen on. And obviously, if you can get Bob, if he's going to smoke, see if you can get him to take the oxygen off while he's smoking the cigarette and move a few feet away from the O2 source. Anything you can do, it's scary to me that somebody would have oxygen on and be smoking at the same time. You can offer smoking cessation assistance. I don't know if it's going to work in this case. Bob does seem pretty set in his ways, so good luck with that. But, and I agree with the majority who voted this way, in the end, I think Bob should get the home oxygen. It's an issue of autonomy. You make sure he has all the information and he makes an informed decision. He does have a right to make his own decisions. Let's move on to the next case. We've all been dealing with this the last few years, required flu vaccines for healthcare workers. And in this case, the hospital requires healthcare workers to get seasonal flu vaccines. I think this is a requirement in most, if not all, hospitals at this point. In this case, it is a written hospital policy, and it was published months ago. The hospital does allow exemptions for medical and religious reasons. If you want a medical exemption, you're required to get documentation from your physician. If you want a religious exemption, you have to get documentation from your clergy person. Now, in this situation, what we have is Jenny. Jenny works for you in the respiratory department, and she refuses the vaccine because it isn't natural. Jenny's very into what's natural and what isn't. She's a vegan, practices yoga, eats a lot of yogurt, whatever else, granola, I guess, whatever goes on with this. So, Jenny has refused. You're Jenny's manager. Should you fire her? Check yes if you think she should be terminated. Click on the X if she should not be terminated. So let's go ahead and vote on this one. And lots of votes coming in. I can see we have a lot more feelings about this one. And we'll give people a little bit longer to vote. And I think that's about all we're going to get there. So let's go ahead and show the results here, Shauna. Are we going to fire her or not? Okay, this is interesting. Most of you would say no, you can't. No, you shouldn't terminate her, and some of you say yes, you should. All righty. I actually didn't expect that result. This is kind of interesting to me. So let's talk about the ethical implications here. And we're getting voting here from people who are forced to take flu vaccines, so this is good. The ethical dilemma here, and I think that most of you who said no, this is probably what you were going on, is Jenny's right not to have her body invaded. This is an intrusion on her personal liberty, and she does have this an autonomous decision for her. That she should not have to get this vaccine. Although I don't know if anybody can get a job in a hospital at all without getting a lot of vaccines already, the MMR and things along those lines. So the next point we have here, though, is we have a need to protect a vulnerable population. You know when you go into health care, or at least you should know, that you have a duty to put the patient first. And these patients are a vulnerable population. Their immune systems are very often suppressed. You have the elderly, you have newborns. And this is an issue of non-maleficence, which I don't think a lot of people think of it that way. But healthcare workers should not harm patients by refusing to get a vaccine. So you have that issue. How do you balance autonomy and non-maleficence? Remember we said your primary duty is to the patient here. So that's an issue. And then we have the fact that this hospital is giving a religious exemption, but not an exemption based on personal beliefs. That's going to get you maybe a little legal problem there. How are you going to argue that somebody's personal beliefs are less valid than somebody else's religious beliefs? In the end, can the hospital fire her? Sure. She violated a written hospital policy. They do have the ability to fire her. Should they fire her? That's up for discussion. There are health care professionals who would go either way on this. So it's a decision that hospitals have to make here. Most of the ones I know of, they do require the vaccine, and they don't allow the personal belief kind of exemption for that. So I guess we didn't solve that issue, but I will tell you, you probably would get fired if you didn't follow this. Our next case that we have here, this is a terminal wean case. And in this one, this is a 24-year-old woman, and this is a modification from a real one. 24-year-old woman, multi-system failure, ARDS. We've all worked with these patients. She's been in the ICU for a couple of weeks now. And her status has really just been going from bad to worse. She's sort of sliding downhill on this. She's currently receiving Pavulon to facilitate ventilation, and I just want to refresh your memory on Pavulon if you don't work with it too much. Pancuronium bromide, and this is a neuromuscular blocker, so it's going to paralyze her. It makes it easier to ventilate her. It does not provide sedation or analgesia, and its side effects last 2-3 hours, something along those lines. So it lasts a little while. It's not like just boom and it's gone. Currently, she's on pressure control ventilation, rate of 35, tidal volume 150, PEEP of 15, and 100% oxygen. Basically, you're in that low volume, high rate strategy because of the severe ARDS. And unfortunately, even with that, her blood gases are deteriorating. She's not oxygenating well, and her pH has been right around 7.0 all day, and you just can't get it any better than that. So that's the situation. This is happening about 8 o'clock at night, so you're dealing with the resident, not the staff physician. And the resident calls the family. They're not there. Calls the family to discuss the situation. And they decide to DC the vasopressors and then turn down the ventilator support. They want to let nature take its course. And a lot of families do make this choice. So the resident instructs you to place the patient on CPAP right now. And remember, just to remind you, this patient has Pavulon on board. She is paralyzed. So the family wants to let nature take its course. The resident gives you a direct order, put this patient on CPAP now. So, should you immediately place the patient on CPAP? Click on the green check mark. If yes, you would follow that resident's order. Click on the red X. If no, you would refuse to carry out the order. And we'll give you a few seconds to vote here. And we still have some votes coming in. A few more people gone here before we lock it down. And I think that's pretty much it. Shauna, would you tell us what our results are? Get that up. And we have very few of you who would follow the resident's order. Most of you would refuse to carry out that order. I'm proud of you. The ethical dilemma here is obviously, well, number one, you do have a duty to follow the physician's order. Residents are physicians. Like it or not, that person is in charge. Now, as we all know, especially if you work in an academic health center, it's fairly easy to just go over a resident's head, and that may be what needs to happen here. The other question we have is the family wanted nature to take its course. Can that happen if the patient is paralyzed? I would say no, that's not natural. That's no more natural than if I walked over there and tied a plastic bag over somebody's head. This is somebody who's paralyzed and couldn't possibly breathe. So this is an issue of non-maleficence. I can tell you what really happened here is what most of you voted for. The respiratory therapist did not follow this resident's order. The therapist tried to convince the resident that this was a really bad idea and why it was a really bad idea. They ended up calling the staff physician who was at home. The therapist explained the situation, and the staff physician directed the resident to change that order. So that came out as you might expect. Phantom treatments. Okay, here we've got Scott. Scott's a well-liked respiratory therapist on the night shift. He's just nice as he could be. Everybody likes him. He's always helpful, that sort of thing. But he's currently having a lot of personal problems. His 4-year-old daughter was just diagnosed recently with leukemia. And then about a week ago, his wife lost her job. So right now, Scott has the only medical insurance for the family. The problem here is both you and a coworker suspect that he's charting nebulizer treatments without actually doing them. You've both noticed when he thinks you're not looking, he'll walk into a room and then come back out less than a minute later and go chart the treatment. And what's really interesting here is this only happens with patients who are unconscious and patients who don't have family members hanging out in the room, so there's really nobody to say yes or no that he did do this. And this has been going on for a couple of weeks that you've noticed it. So, should you report Scott to the supervisor? Remember, he's got this little girl who's got leukemia. He's carrying the only health insurance for the family. Real difficult situation. He's going through a bad time. So I want you to click on the green check mark if you would report Scott to the supervisor, the red X if you would not. Let's go ahead and vote. Give you a few more seconds here to vote. Cute little girl, cute as a button, curly red hair, big blue eyes. Says, "Daddy, why am I sick?" I'm getting some more votes in here. I'm not swaying you at all, I'm sure. Okay. And I think we're about set there. What do we have, Shauna? See our results. And a few of you wouldn't report. Most of you would. By about we'll say 4-to-1 margin here, most of you would report. Now, before we discuss this, I have case 6B. And in case 6B, we have Helen. Helen's on the night shift. She moved there, moved to your area from an out of state. She's worked there about 6 months. Most of the staff really don't like Helen. They find her to be rude and unpleasant. In fact, you and your coworkers just mostly try to avoid her. She's in fact been written up for arguing with nurses. And again, you and your coworker, same situation, suspect she's charting nebulizer treatments without actually doing them. Same situation as Scott. You see her walk into a room, walk back out 30 seconds later and go chart the treatment. In fact, one time as she's walking out, she actually sees you and she just sort of grins and shrugs her shoulders and walks on and charts the treatment. So, given the situation, would you report Helen to your supervisor? Green check mark if yes, red X if no. A few more seconds here. Still have people voting. Get it going on a little bit more. And we'll close out here in a couple of seconds. Okay, Shauna, what do we have as our results here? Hardly anybody's going to stick up for Helen here. That almost all of you are going to report her. This is much different from what happened with Scott with the cute little girl with leukemia. So what horrible thing have I done to you here? And obviously I sort of swayed this a little bit for teaching purposes. The ethical dilemma here, and it's the same case. You have the same ethical dilemma with Scott as you do with Helen. So you can't remember that you can't forget rather that your primary duty is to the patient. I know Scott's your friend, got the cute little kid. No matter what his personal situation is, your primary duty is to that patient. You don't want to falsely accuse a coworker, but the thing is you don't have to make an accusation. All you're reporting to your supervisor are the facts of what you've actually seen. You do not need to draw conclusions from that. You're worried this could have serious consequences for Scott or Helen. Obviously, certainly that makes the stakes higher, but it really doesn't change your duty to the patient. Is this an either-or situation? Do you report, not report? Not entirely. You do need to let your supervisor know what you've seen. You just got to do that, sorry. But you might want to let Scott or Helen, if you can stand to talk to her, know what you're going to do and give them the opportunity to go talk to the supervisor first and confess or explain or whatever. Which kind of brings us to, I think, what's the most notorious case of respiratory therapists failing to report the wrongdoing of a coworker. And this is an actual case called the Angel of Death, and it involves a man by the name of Efrain Saldivar. He was a respiratory therapist in Glendale, California. And in 1998, a coworker reports to the supervisor that he's seen unauthorized drugs in Saldivar's locker and believes that Saldivar has been administering them to the patient. The drugs here are Pabulon again, which we just discussed, and succinylcholine, which is also paralyzing. And the thing is, other coworkers fail to report this, even though later, during the investigation, they admit that they've actually seen the same thing. So they saw these drugs in his locker. Lots of people apparently suspected what he was up to. Only one person finally reported it. And from what I've read, the supervisor he reported it to kind of discounted it a little bit because he thought it was just a personal issue between the two. So what happens then is Saldivar is brought into the police, and when the police are discussing this with him, he admits to killing up to 50 people. He thinks 40 or 50, not quite sure. But the problem is that he then later recants this admission. Apparently he's a little loopy when they're interviewing him and they're having trouble getting a straight answer. And the police don't arrest Saldivar because he recanted, and that's the tricky part here. He did recant, and they really don't have corroborating evidence. That they don't think it's strong enough somebody saw this stuff in his locker to be good, strong evidence. The hospital does obviously fire Saldivar. They initially suspended the entire respiratory department, and then they ended up only firing 4 of the respiratory therapists. The state licensure board in California obviously pulled his license, so he couldn't work in respiratory therapy anymore, thank goodness. And then the police are investigating. Why this took so long, I have no idea. But the police are continuing to investigate, and finally they get permission to do autopsies. They actually ended up exhuming 20 bodies and started doing autopsies. Now, succinylcholine, if it was in fact used, and they didn't prove that that was used, it breaks down fairly quickly in the body, so that's not something they thought they would find on autopsy after they exhumed these bodies. But they did, in 6 cases, find victims with Pabulon on board. So this all goes down at this point, and they end up charging him with 6 counts of first-degree murder. He did plead guilty to avoid the death penalty and ended up with life without parole. He's serving 6 consecutive life sentences. So this is a case, obviously this is a lot worse than not giving a nebulizer treatment, but this is a case that the issue is people knowing wrongdoing is going on and not reporting it. And that is a massive ethical failure of epic proportions. And I still can't get over the fact that these people did not report. Now, some states may have in their legal system a duty for you to report. So you want to take a look at that, make sure you know the law. But even if there's no law that says you have to report, ethically you should do that. Now, as you come across these ethical issues, you shouldn't really have to work out all of these problems by yourself. And some of these can be fairly thorny. Do you have help for working these out? Well, most hospitals do have some sort of an ethics committee, and this is important. You should find out if your hospital or your employer does have an ethics committee. It's important for this to be in place before the problem arises. As we all know, these sorts of things tend to happen at 2 in the morning on a weekend, and it's hard to come up with an ethics committee on the spur of the moment. So this should be in place ahead of time. This is typically a multidisciplinary group. It includes caregivers, doctors, nurses, respiratory therapists. Not all the committees include respiratory therapists, but if you have an interest in this, or if this is something that comes up a lot in your practice, you might find out where the ethics committee is in your hospital and volunteer for it. And there typically is training that will go along with this too, so if you volunteer, you're not just sort of walking into a room and making these really important decisions. They will go over some training with you. So we have caregivers. We usually have clergy. A lot of ethical decisions or decision-making that happens with families and patients is religion-based. So you need to have the clergy in there, preferably more than one religion, so that you get a variety of views. An attorney. A lot of this has legal implications. You really need to have legal counsel on your ethics committee to see what you legally can or can't do. An ethicist will be wonderful to have. These can be hard to come up with if you're in a small town, but perhaps you can contact the state university and get somebody from there who would Skype into your meeting. So that would be helpful. Basically, your group should be culturally diverse so that there are different viewpoints, and you want to have the kind of diversity that represents your patient population that you're going to have to deal with. What's the function of the Ethics Committee? Obviously, they're going to provide consultation when ethical dilemmas arise. As I said, they need to be available 24/7 because bad things always happen at night or on the weekends. It's just the way things happen. They're going to help staff and family or patients arrive at a decision. Typically, the Ethics Committee is not an absolute authority that hands down some sort of edict that says you must do this or you can't do that. They might if it's a legal situation. But they do try to work with families and staff to come to a solution, come to a consensus. That is very important because then people have closure, the families have closure when the incident is over. And they need to develop policies on handling ethical dilemmas. These need to be done ahead of time, that you can check with other healthcare providers, other hospitals in your area or in the state to see what they're doing around ethics committees. Now, your supervisor or director should be able to advise you on how to contact an ethics committee. If it's an odd time of night or weekends, a lot of times there's an administrator on call, and they can take care of that issue as well. Now, before we go to questions, there are some people I want to thank when I put out the call for help with this and getting situations. These are the folks who did help me. I'm not going to tell, well, I already kind of outed Shauna, but the rest of them, I'm not going to tell you who sent me which cases, but I just want to express my thanks to these people. So now we're open for questions. So if you found any questions you want to ask me, Shauna, we can do that now.
Linda. Actually, we have fantastic comments in the chat room. It has just been on fire the whole time you've been talking. Okay. Not a whole lot of questions, but a lot of debate back and forth with the cases, which is, of course, the entire purpose behind what you wanted to do today. So the first question that I want to ask you is actually with your last topic of the seminar, which is the ethics committee.
Yeah.
When is the appropriate time to pull in the ethics committee? Is there a time that's too soon? Is there a time that's too late? How is that timing determined?
Boy, this is so situational. What I recommend, if you're a staff therapist, what I recommend you do first, talk to your supervisor, talk to your medical director, talk to your department director. And if the situation is still one that you just think you're being asked to do something that's wrong or there's something wrong going on with the patient, a lot of hospitals have the policy that you can then contact this ethics committee and get their input. Some people it comes down to, I'm sorry I can't do this, fire me if you have to, but I just can't do this. But you being fired doesn't change what they're about to do that you disagree with. So I think having the gumption to work through an ethics committee is the way to go. But I mean, you don't jump straight to that. You first talk to your supervisor and your medical director and your department director on that.
Thank you very much. The only other real question that we have is about informed consent. And you were clear telling us that the patient has to have decisional capacity to consent to refuse therapy. What about a patient who is somnolent? At what point do you intervene to try to get that patient up to decisional capacity? Is there an ability to do such a thing?
It depends on why they're somnolent. If you have the ability to modify their medication, like happened with that hunter, to modify their medication to bring them up to full cognitive ability, you can do that. That's not within your scope of practice to assess level of consciousness and that kind of thing, so you would need to bring in a medical expert on that. You can certainly say to the physician, obviously, if you can't wake them up, then that's too somnolent. But if there's any question on it, you need to get in an expert whose area that is, a neurologist or a psychologist or somebody along those lines, who can actually assess that. If you can safely change the medication so that they are more awake, then yes, I think that would probably be the way to go.
Fantastic. Well, thank you very much, Linda, for joining us today.
Thank you.
For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, this concludes our presentation.